Good morning and hello, everyone. My name is Miernik. I'm senior consultant, a urologist working at the University Hospital Freiburg in Germany. Um, I'd like to tell you a little bit about laser enucleation of the prostate that is based on the pThuLEP technology. The laser has been developed in my lab in the last year, and now it's in successful clinical use. We have done many hundred cases for BPH on various patients having various prosthetic glands. And I'd like to show you a video demonstration of Tullio laser enucleation of the prostate, how we do that at the university hospital, and of course uh, elaborate on some important details. So I will share the screen and you will see a video that I presented in the past at a urology conference. And in this video, I will guide you step by step um, throughout this procedure. So now I have to find the proper window, and I think everything is good. Um, and there are, of course, different ways how to execute endoscopic transurethral enucleation of the prostate. I will show you an example, very straightforward one. A male patient, of course, 64 years, 75 mils prostate volume, suffering from BPH-related symptoms. Now we can stop a little bit and dive into the more technical details of the equipment. We've got a 100-watt Tullio laser system. This is a thulium YAG laser, solid state pulsed laser operating at the wavelength around 2 me. That is that is great for perfect water absorption and delivering energy uh, in the urinary tract on site where you need this energy, for instance, to cut or dissect or coagulate something, and so on and so forth. I will be using 600 micrometer fiber, and the setting is 2 joule, 50 hertz, giving you 100 watt. And this is already preset for enucleation. Also, and the endoscopic equipment from the company Richard Wolf encompasses this 26 Sharir laser resectoscope, having a dedicated working channel to for introducing laser fiber. And at the end, I will perform morcellation using the Piranha system from Richard Wolf. So having said that, let's talk a little bit more about the Tullio laser. So the good thing and very important thing is that the laser combines both words, simply speaking. So there are some limitation of the holmium word, and there are also limitation of the TFL word. And Tullio tries to combine those properties. I will explain a little bit more throughout the video. You can use short pulse and for instance, having a relatively high peak power that is much higher than in TFL system. And this peak power gives you nice explosions of those water vapors that you need to separate the plane. And the laser is, of course, well suitable for treatment of urinary stones and BPH. Uh, The whole chassis is relatively small, and the system itself silent, and you can use the standard electric power connector that is 240 volt in Europe or in the European Union. So the lasers look like this. It operates on the wavelength of 2013 nanometer, and let's step back a little bit, has the maximal peak power, and this is very important, at 3700 watt. And this is relatively comparable to holmium systems. So the key takeaway here is that the laser is comparable in its peak power to a holmium system. Here you can see the setup from our OR. You can see this wireless foot pedal. There is also like a wire connected foot pedal, and already the shaft is in the patient. Now I'm inspecting the endoluminal cavity of the lower urinary tract, and you can see the kissing lobe phenomenon. It means that the prostate is pretty enlarged, and in the bladder there is a stone, bladder stone. So on this demonstration, you will also see the performance of the laser on uh, on the stone. So so I think many of you have encountered this issue, this problem, that you have to explain the setting to the surgeon, to the practitioner, and here there is mostly there are some presets. So the good thing is that you can choose for stone disintegration, like here, that you aim to create more dust, more small fragment. You can also choose some presetting for creation of larger but more heterogeneous fragments. This is fragmenting, and the laser is also very good in the reduction of retropulsion. So here there is not much movement of the stone, and you can see that I'm fastly proceeding, and fastly, very nicely disintegrating the stone, and there is not much cut in this video, and you see after a couple of minutes the stone is gone. Now we are moving towards the real reason for the operation, and this is the enucleation. Here maybe a short step back and pause. If you want to learn more about the surgical technique, would like to I would like to recommend you this publication. It comes from our group, and it's about the technique that we call three horseshoe-like incision technique during, at that time, holmium laser enucleation. Nowadays, of course, thulium-based enucleation of the prostate, and then you can learn step by step how to do that. There are, as already mentioned, different variation of this approach. Our idea is to simplify the orientation. Orientation is the most problematic thing, and building on this point, we want to shorten the learning curve. So the learning curve is mostly affected by the difficulty to find the surgical plane. And it it is not that easy in real life. So here you can see I'm cutting around the verumontanum, and I'm exposing the surgical plane easily by pushing a little bit the tip of the shaft, and this movement is actually very important. There are basically three forces that you can use during transurethral enucleation. The first one, I call it um, macro mechanical manipulation, micro mechanical dissection, when you use just the tip of the shaft, like your finger, while doing open enucleation. That is actually outdated nowadays, but those of you who are familiar with technology have heard about that. So you just use your finger for dissecting the plane, and in this situation you would use the shaft. The second energy or force source is just the macromechanical energy that is provided by explosion of water that are not well visible here, but they are there. This is like a micro swarm of small bubbles exploding around, and those this force, those bubbles, just spread this surgical plane apart. And the third force is just coagulation. So you can see here coagulation, thermal energy that is provided to tissue just for closing vessels, for ensuring the safety of this procedure, and also for cutting. So just balancing those energies give you very nice performance and also great experience if it comes to enucleation. So you can see I'm just like dancing on the plane, and now here already the bladder neck is already open. So I have entered the bladder neck, and now just cutting around the mucosa, just covering the bladder neck, and this step is it looks at least easy. Um, but let's unpack it a little bit more. Um, in some videos, or maybe talking to other practitioners, or watching um, maybe videos online, you can see different approaches. Here we are I'm trying to enucleate the prostate in one piece. So this technology or this technique is called en bloc. You may also do it in two lobes or three lobes. So it would be called two-lobe or three-lobe technique. Here, as already mentioned, the simplification of the orientation is our goal. And I think as soon as you've found the surgical plane, you can just take it from there. You can just follow the plane, gaining land. So this is the probably simplest explanation to do that. But sometimes some surgeons just cut within the adenoma, so they are not really on the plane, and this is also something that may affect their validation of the laser. And the good thing is that the laser gives you a lot of safety and precision when you are not on the plane, because on the plane you are using a lot of macro mechanical energy. But sometimes when you are lost and there is no plane and you have to just cut your way through, um, coagulation and cutting that is better in the thulium world gives some relevant add-on to the safety. Now I am deattaching the mucosal strip, so there is a connection between the external sphincter and the adenoma, and I'm just pushing this tissue away, just as as said. Uh, um, I'm gaining the plane, and there is of course a lot of experience, particularly here, how to manage the bladder neck, how to master the orientation, how to probably just be fast, how to prevent the external sphincter, and many more. Uh, but having perfect energy source like Tullio gives you just yeah much more safety, and safety is very important, particularly at the beginning of your learning curve. So I think the performance of the laser speaks for itself. Here we are at the level of the median lobe, very nicely separating it from the peripheral zone. It's not reinventing the wheel, but something that can be just incrementally be done better. Now it's not much left to finish the procedure. You can see that we are approaching the bladder neck from below at 6 o'clock, and that the tissue is very movable, very flexible, and then we push it into the bladder, and we can morcellate it from there. So now it's the also important step just to gain more space in the fossa, to just push one lobe into the bladder and then focus on the other one. So there are mostly some attachments still there, and you can control them nicely using the laser. So probably you have mentioned that there is almost no bleeding throughout the procedure. So one reason for that is, of course, the great performance of Tullio, but other reason is that we have a high endoluminal pressure, and this pressure comes from highly hanging irrigation bags, and that's why this hydraulic pressure just closes the vessels. Yeah, so we are now really finishing the job. Adenoma will be in the bladder very soon, and the next step will be HF current-based, high-frequency-based hemostasis. And maybe have you ever wondered why we do stick to this step? Some people, of course, use solely the laser. So there are many reasons. I'm not very dogmatic. I accept the strategy. If someone uses the laser, I consider this faster and slightly better. One thing is that we now have lowered the intraluminal pressure by lowering the bags. So I'm actually forcing the vessels to open up again if there are any unclosed vessels, to let them bleed, to let them be visible, and then I can nicely manage the bleeding. Mostly there are small bleedings. I want to have the patient really having crystal clear irrigation. In Germany, at least, there is need to keep the patient 2 days on the ward for full reimbursement, but maybe in other countries, or maybe soon in Germany, the policy will change, or there are different policies, and I basically want to have the patients same day discharge ready. So now the third step of the procedure, morcellation. Also a lot of knowledge is and experience, a huge skill set is required to master this step. Some people consider morcellation at the same level of complexity than enucleation, and of course it may look like this. I mean, easy going, but in fact, the stone fragment being in the orifice, of course, there is no need to remove that. It just looks, yeah, differently. And now you can see a nice broad fossa of no obstruction anymore. So the main features of the Tullio laser system are optimized energy profiles for simultaneous cutting and coagulation during enucleation. And basically, this is also a very important feature. from my point of view, you don't have to change the pedals, what some people do. With one pedal, just changing the distance of between the fiber tip and tissue, you can coagulate and cut. And the energy impact is more precise because the absorption in water is better than in Holmium systems, and it gives you a very good hemostasis that is sometimes even more needed, particularly if you are lost, if you are not on the plane but in the adenoma, what can happen particularly at the beginning of the learning curve. So now I will switch to another movie because I've got also something very interesting, another technique, and I have presented this video. It's 703. Let me skip to that. Okay, here you go. I presented this technique already many times. It's a variation of the classical enucleation uh, towards some towards a technique allowing the patient to have better continence postoperatively. This is also another a very important topic, complication of this procedure. So the major complication is permanent incontinence, but there is also something that we call transient incontinence. It means um, problems with just keeping urine in your bladder, but of temporary nature. So it will dissolve, it will vanish after a couple of months, but it's of course bothering at the beginning. And there is an anatomical structure that is called lysosphincter, and this is a connection, something like suspension being between the external sphincter and the bladder neck. There is no not much information out there about this structure, about its importance. Um, there are anatomical studies from groups working on incontinence improval after radical prostatectomy, and there is knowledge that this structure just keeps uh, the external sphincter in place. Every structure requiring or moving frequently requires some fixation points, and these fixation points is just granted by the lysosphincter. And normally doing classical TURP, I mean the resection of the prostate with a loop, you will resect that. And now we have just growing evidence, growing observation that the preservation of this structure improves postoperative continence, giving the patient so-called rapid postoperative continence, in contrary to patients after regular regular resection or regular enucleation suffering temporarily from incontinence. This is, of course, a very broad topic. It's not just stress urinary incontinence, but also urge. So many people having just something that is called functional disbalance, disequilibrium, because the bladder had to work against resistance over years and decades, and just like overnight the resistance is gone. I mean the obstruction, infravesical obstruction caused by BPH, so the resistance is gone and the bladder is like overtrained. It's just too strong, so and the reaction is just too strong, and that's why it has to come down. It has to come to balance, and also the external sphincter is mostly too weak, and the third factor is just a fresh wound of the fossa, and it gives some urge to the patients. Of course, this will dissolve. It will be gone within 3 to 6 months after the procedure. Now, let me illustrate the reason behind preserving the sphincter, sorry, the lysosphincter, this bridge between the external sphincter and the bladder neck. Here, we are not doing a circular enucleation, circular removal of the adenoma, but restrict ourselves to the lateral lobe and the anterior part, anterior commissura is being spared. This requires to cut a little bit through the adenoma, so there will be small adenoma rest, probably particularly in larger prostate, just contributing to the lysosphincter. It's not that easy to separate the lysosphincter. If you try to do so, there will be very fragile strip that may tear during the procedure. That's why you have to keep a little bit of tissue up there. So I cannot emphasize more how important it is just to have perfect orientation, and orientation is also something that relies on, of course, visibility. It's not like your three-dimensional perception of the anatomy in your head, but also something that you just recall based on that what you see. And here again, having extremely good visibility that is given by lack of bleeding, it's something that absolutely impacts the precision, impacts the postoperative outcome of the patient. That's why the wish had been to have a laser combining both, not compromising like the speed. And so the speed is alone through that higher, in my opinion, than during a Holmium procedure. And you can see that now I'm dissecting the tissue on the other side with ease. So it's not just theory. There are a lot of publications out there, a lot of data knowledge. Also, the human factor is very important. There is not much standardization about the surgical technique. Also, the setting like irrigation can impact the performance. So some minor factors that cannot be really discussed or displayed in the publications. Now, just for your information, we also have published data on Tulio, but again, the comparability of individual publications, particularly coming from surgical studies or studies on surgical techniques, have been difficult, and this is something that is not gonna change in the future that easy. Yeah, so the same, now we actually have deattached the prostatic tissue, adenoma tissue, and you can see here the sphincter looks differently. I will maybe stop a little bit, and you can see this bridge, this very broad, strong, thick strip connecting your external sphincter to the bladder with the bladder neck. And we have not much data on that, but from the experience and from phone calls with the patients, we know that they are like happy, superbly happy, uh, having almost no uh, early post-operative incontinence. So, so thank you for the possibility to bring it up to you. I hope this package of information is good. If there is need for some more for more discussion or for elaborating some particular aspects, I'm happy to answer them in webinar or directly. I think this is a good introduction to pThuLEP-based enucleation of the prostate, and a little bit in a nutshell, um, but the bottom line is clear. Good laser is essential for a perfect and safe procedure. And I wish you a good day. Thank you very much.